The morning sun barely broke through the gray clouds hanging over Metropolitan General Hospital as Dr. Amara Williams pushed through the heavy glass doors of the main entrance. Her scrubs were crisp and navy blue, and she carried a leather folder tucked under one arm. Today was her first official day as the hospital's new medical director, though she'd specifically asked the administration to keep that information quiet for now. She wanted to see how the hospital really operated, without everyone being on their best behavior because the boss was watching. She'd spent the last 2 weeks reviewing files, sitting in on meetings and observing from the shadows. What she'd seen so far was encouraging. Metropolitan General had a solid reputation, good patient outcomes, and a dedicated staff. But Amara had learned long ago that the real story of any hospital wasn't found in statistics or reports. It was found in the daily interactions between people, in how doctors treated nurses, in how everyone treated patients, and in the small moments that revealed someone's true character. The elevator bank was busy with the usual Monday morning rush. Doctors, nurses, administrators, and visitors all crowded together, waiting for the next available car. Amara stepped into line, her eyes scanning a patient chart she'd grabbed from the nurse's station. It was a complex cardiac case, the kind that interested her even after 20 years in medicine. The patient was a 62-year-old man with a history of heart disease, and something about his recent test results wasn't sitting right with her. The elevator dinged, and the doors slid open. Amara stepped inside along with several other people. She moved to the back corner, still absorbed in the chart. That's when she noticed him. He was tall, probably in his late 40s, with salt and pepper hair styled perfectly. His white coat was pristine and his posture screamed confidence, the kind that bordered on arrogance. He was talking loudly on his phone, not bothering to lower his voice even in the confined space. "I don't care what the nurse thinks," he said into the phone, his tone sharp. "I'm the surgeon. I make the calls. Just do what I told you." He ended the call with an irritated swipe and shoved the phone into his coat pocket. The elevator filled up quickly and Amara found herself standing not far from him. She offered a polite smile and a small nod, the kind of professional courtesy healthcare workers exchange dozens of times a day. He glanced at her, his eyes moving from her face down to her scrubs and back up again. There was no smile in return. Instead, he looked right through her as if she were invisible, and turned his attention to his own phone, scrolling through emails with a frown. The elevator lurched upward. Amara went back to the chart, her mind working through the patient's symptoms. The troponin levels were elevated but not dramatically. The EKG showed some irregularities, but they could be interpreted different ways. She'd seen cases like this before where everything looked borderline until suddenly it wasn't. The key was in the details, in connecting symptoms that seemed unrelated. "Excuse me," Amara said quietly, noticing the man's badge. "Dr. Richard Thornton, cardiac surgery." "You're a cardiac surgeon?" He looked up from his phone, clearly annoyed at being interrupted. "Yes, why?" "I was just reviewing this case," Amara said, holding up the chart slightly. "This patient, Mr. Patterson, his presentation is interesting. The troponin levels are borderline, but combined with his history and the subtle ST changes on his EKG, I'm wondering if we should be more aggressive with—" "Sorry, are you his nurse?" Dr. Thornton cut her off, his eyebrows raised. "I'm reviewing his case," Amara replied calmly, "and I think there might be—" "Look," he interrupted again, his voice taking on a condescending edge that made several people in the elevator shift uncomfortably. "I appreciate that you're interested in patient care. That's great, really. But cardiac cases are complex, very complex. They require years of specialized training to properly interpret." Amara felt her jaw tighten, but she kept her voice level. "I understand that. I was simply suggesting that the combination of factors might warrant what exactly?" Dr. Thornton said, turning to face her fully now. His voice grew louder, addressing not just her, but seemingly everyone in the elevator. "Let me guess. You took 1 semester of anatomy and now you think you can read an EKG? You think you understand cardiac pathology?" The elevator was completely silent now except for the mechanical hum. Everyone was carefully looking anywhere but at them. "I have experience with these cases," Amara said quietly, "and I'm concerned that—" "Your concern is noted," Dr. Thornton said in a tone that made it clear he found her concern worthless. "But here's the thing you need to understand. There's a hierarchy in medicine. There's a reason doctors go to school for over a decade. There's a reason we make the medical decisions and nurses follow orders. It's not personal. It's just how it works. Amara felt her face grow warm. She'd experienced this before, many times over her career. The assumptions. The dismissals. The way some people looked at her and saw only her race, her gender, her scrubs, and decided they knew everything about her capabilities. "I'm not trying to overstep," Amara said, her voice still calm but with an edge of steel underneath. "I'm trying to advocate for a patient who might need more aggressive intervention than what's currently planned." Dr. Thornton let out a short laugh. "Advocate, right, look, I'm sure you're good at taking vitals and changing bedpans. Stick to that. The actual medical decision-making? Leave that to people who are qualified." A young resident standing near the front of the elevator winced visibly. A nurse in pink scrubs stared at the floor, her lips pressed into a thin line. An older man in a suit looked like he wanted to say something but thought better of it. Amara took a slow breath. She could feel her heart pounding. But years of dealing with people like this had taught her that losing her composure would only confirm whatever stereotypes were already in his head. "I see," she said simply. "Do you?" Dr. Thornton continued, apparently not done. "Because I've noticed a trend lately. Everyone thinks they're a doctor. Everyone thinks their opinion matters equally. But it doesn't. A nurse's opinion on cardiac surgery is not equal to a cardiac surgeon's opinion. That's not discrimination. That's not being mean. That's just reality." The elevator dinged. Third floor. The doors opened, but no one moved. "You know what the problem is these days?" Dr. Thornton went on, seemingly oblivious to the discomfort radiating from everyone around him. "Nobody wants to stay in their lane anymore. Everybody wants to be in charge. Well, guess what? Some people earned the right to be in charge. Some people put in the work." He looked directly at Amara. "If you want to make medical decisions, go to medical school. Until then, maybe focus on what you were hired to do." The elevator doors started to close and someone hit the button to keep them open. Still no one spoke. Amara met his eyes. She'd been in medicine long enough to recognize this type. The kind who saw challenges to their authority everywhere. The kind who needed to feel superior to everyone around them. The kind who used credentials as weapons and hierarchy as a shield for poor behavior. "Your floor, doctor?" someone asked nervously from the front of the elevator. "Fifth," Dr. Thornton said, finally breaking eye contact with Amara to check his phone again. "Cardiac unit," the doors closed. The elevator continued upward. No one spoke. The silence was thick and uncomfortable. The kind that settles over a room when everyone has witnessed something wrong, but no one knows quite what to do about it. Amara looked back down at the chart, though she wasn't really seeing it anymore. Her hands were steady, but inside she felt the familiar mix of anger and exhaustion that came with moments like these. How many times? How many times in her career had she been underestimated, dismissed, talked down to? How many times had people looked at her and made assumptions about who she was and what she knew? The elevator stopped at the 4th floor. 2 people got off quickly, clearly eager to escape the tension. It continued upward. When the doors opened on the 5th floor, Dr. Thornton stepped out without a backward glance. As he walked away, Amara heard him mutter to a colleague who'd been waiting for him. "Can you believe that? Nurse trying to tell me how to do my job. This place is going downhill." The doors closed again. Amara was alone in the elevator now, except for one other person, a young woman in administrative attire who'd been standing quietly in the corner the whole time. "I'm sorry," the woman said softly. "I'm sorry you had to deal with that." Amara offered a small, tired smile. "It's not your fault. Still, that was wrong. Everyone knows Dr. Thornton can be difficult, but that was just—" She trailed off, shaking her head. "Has he done this before?" Amara asked. The woman hesitated. "I probably shouldn't say anything. I'm just in billing, but yeah, I've heard stories. Lots of stories." The elevator reached the 7th floor. The administrative wing. Amara's new office was here, though almost no one knew it yet. "Thank you for saying something," Amara said as the doors opened. "Most people don't." She stepped out into the hallway, her mind already moving past the encounter and toward the larger implications. If Dr. Thornton spoke to her that way in a crowded elevator, full of witnesses, how did he treat people when no one was watching? How did he treat the nurses on his unit? And more importantly, how had he been allowed to behave this way for what sounded like a very long time? Amara walked toward her new office. the leather folder still tucked under her arm. She passed her own name on the door, Dr. Amara Williams, medical director. She didn't go inside. Instead, she turned and headed back toward the elevators. There was work to do. Real work. The kind that couldn't be done from behind a desk. But first, she needed to check on Mr. Patterson, the cardiac patient from the chart. Because regardless of what Dr. Thornton thought, those test results really were concerning. And if her instincts were right, that patient needed someone willing to ask the hard questions and push for the right care, even if that someone was just a nurse. At least that's what Dr. Thornton thought she was. Amara pressed the elevator button and waited. Her expression was calm, professional, but behind her eyes, there was a determination that came from years of fighting to be heard, to be respected, to be seen as the physician she'd worked so hard to become. Dr. Richard Thornton had no idea who he'd just dismissed in that elevator. No idea at all, and Amara suspected that when he finally found out, it would be a conversation he wouldn't forget. 3 days had passed since the elevator incident, and Amara had been watching, not obviously, not in a way that would draw attention, but with the careful observation of someone who knew that the truth of any organization lived in its daily rhythms, not its policies and procedures. She'd spent Tuesday shadowing the emergency department, sitting in on morning rounds, listening to how doctors and nurses communicated with each other. Wednesday, she'd visited the pediatric wing and the intensive care unit. And now, on Thursday morning, she found herself on the 5th floor, the cardiac unit, Dr. Thornton's domain. The nurses' station was busy, as it always was around 8 in the morning. Charts were being updated, medications were being prepared, and the night shift was briefing the day shift on each patient's status. Amara sat in a corner with a cup of terrible hospital coffee, wearing her scrubs and an ID badge that identified her only as Dr. Williams, with no title listed. To anyone who glanced her way, she looked like just another physician reviewing charts. Dr. Thornton wants the post-op patients ambulated by 9, a nurse with short black hair was saying to her colleague. Her name tag read, Kelly Chen. She looked tired, the kind of tired that came from a long shift, not just a long night. All of them? The other nurse asked. This one was younger, maybe mid-20s, with nervous energy that suggested she was relatively new. Her badge said Bethany Moore. That's what he said. Kelly's voice was carefully neutral, but Amara caught the slight tension in her shoulders. But Mrs. Rodriguez just came up from surgery 4 hours ago. She's barely stable, and Mr. Johnson's blood pressure has been all over the place. Walking might— I know, Beth. Kelly cut her off gently. But you know how Dr. Thornton gets if his orders aren't followed exactly. Bethany lowered her voice, but Amara could still hear her. Can't we just explain that it might be too soon? That we should wait until— You can try, Kelly said with a slight shake of her head. But I've been here 6 years. Trust me, it's easier to just do what he says and keep a close eye on the patients. Document everything. If something goes wrong, at least we'll have it on record that we had concerns. Amara felt something tighten in her chest. This was exactly the kind of thing she'd been looking for, but it still bothered her deeply. Nurses modifying their medical judgment not based on what was best for patients, but based on a doctor's temper. She watched as Bethany walked away, her face troubled. The young nurse stopped at a patient's room, took a deep breath, and went inside. Through the open door, Amara could see her checking vitals with extra care, probably trying to determine if the patient was truly stable enough for what had been ordered. An hour later, Amara was reviewing medication logs when she heard raised voices coming from down the hall. She stood up and walked toward the sound, staying just far enough back to observe without being obvious. Dr. Thornton stood outside a patient's room, his face red, his finger pointing at a nurse Amara hadn't seen before. The nurse was a tall man with dark skin and close-cropped hair. His badge read, David Okonkwo, and despite Dr. Thornton being several inches shorter, he somehow managed to loom over the nurse through sheer force of anger. Are you questioning my medical judgment? Dr. Thornton's voice carried down the entire hallway. No, sir, I'm just— David started. Because it sounds like you're questioning my medical judgment. It sounds like you think you know better than a cardiac surgeon with 15 years of experience. Dr. Thornton, I'm only trying to tell you that Mr. Harris's oxygen saturation dropped to 87% about 20 minutes ago. It's back up now, but combined with the chest pain he reported and the irregular heartbeat, I thought you should know before we what? Before we proceed with the treatment plan that the actual doctor, determined was appropriate. Dr. Thornton crossed his arms. Let me explain something to you. Those symptoms are expected post-surgery. They're normal. If I changed my treatment plan every time a nurse got nervous about normal post-operative symptoms, none of my patients would ever receive proper care. I understand. But the combination of all three symptoms together seemed significant to who? To you? Dr. Thornton's voice dripped with condescension. And what exactly are your qualifications for determining cardiac significance? Did you go to medical school when I wasn't looking? David's jaw clenched, but he kept his voice professional. I've been a cardiac nurse for 8 years, doctor. I've seen hundreds of post-op patients. This felt different. It felt different, Dr. Thornton repeated mockingly. Well, thank goodness we have your feelings to guide us. Here I was relying on science and medical training like a fool. A few other nurses had stopped what they were doing, watching the exchange with expressions ranging from sympathy to resignation. Clearly, this wasn't the first time they'd witnessed something like this. I'm documenting my concerns in the chart, David said quietly. You do that, Dr. Thornton shot back. And while you're at it, maybe document that you should focus on following orders instead of playing doctor. That's what you're here for. To follow orders, not to think. Not to question. To do what you're told by people who actually know what they're doing. He turned and walked away, leaving David standing there, his hands balled into fists at his sides. The nurse took several deep breaths, clearly trying to compose himself before going back to work. Amara waited until Dr. Thornton had disappeared around the corner, then approached David. Excuse me, she said quietly. Are you okay? David looked at her, and for a moment she saw the frustration and hurt flash across his face before he locked it down behind professional composure. I'm fine. Just another day. That shouldn't be just another day, Amara said. Yeah, well. David shrugged tiredly. It is what it is. How often does this happen? David studied her for a moment, clearly trying to decide how much to say. You're new here, right? I haven't seen you around before. I am, Amara confirmed. I'm just observing different units, getting a feel for the hospital. Then take my advice, David said. If you end up working this floor, develop a thick skin. Dr. Thornton runs this unit, and he doesn't like being questioned. Especially by, he trailed off. By? Amara prompted gently. David hesitated, then seemed to decide he'd already said too much. Just develop a thick skin. Document everything, and learn to pick your battles. He walked away before she could ask anything else. Amara spent the rest of the morning on the cardiac floor, and the more she saw, the clearer the pattern became. Dr. Thornton wasn't just dismissive in elevators. He wasn't just having a bad day. This was who he was, consistently and persistently. She watched him breeze past a Filipino nurse named Christina, who tried to ask about a patient's medication dosage, waving her off without even slowing down. She overheard him on the phone with someone, complaining about diversity hires lowering the quality of staff. She saw the way nurses tensed up when he entered the room, the way they seemed to calculate every word before speaking to him. But what bothered her most wasn't just his behavior. It was the system that had clearly allowed it to continue. The other doctors who looked uncomfortable but said nothing. The nurses who'd learned to work around him rather than confront the problem. The entire culture that had adapted to accommodate one man's ego and prejudice instead of protecting the people he hurt and the patients who deserved better. By lunchtime, Amara had made a decision. She headed to the Human Resources Department on the second floor. The HR director was a woman named Patricia Hoffman, probably in her late 50s, with reading glasses hanging from a chain around her neck and an office that smelled faintly of herbal tea. Dr. Williams, Patricia said, standing to shake her hand. It's good to finally meet you in person. How are you finding Metropolitan General so far? Educational, Amara said carefully. Actually, that's what I wanted to talk to you about. I need to see all formal complaints filed against Dr. Richard Thornton. Patricia's welcoming smile faltered. Dr. Thornton? From cardiac surgery? That's the one. May I ask why? Patricia sat back down slowly, and Amara noticed her hand move almost unconsciously toward a drawer in her desk. I'm the medical director, Amara said simply. I don't need to explain why, but I will tell you that I've observed concerning behavior that suggests there might be a pattern. If there are formal complaints on file, I need to see them. Patricia looked distinctly uncomfortable. Dr. Williams, I want to be helpful. I really do. But personnel files are sensitive, and Dr. Thornton is a very respected surgeon. He brings in significant revenue for the hospital, and his patient outcomes are excellent. Whatever you might have seen, I'm sure there's context. Ms. Hoffman. Amara's voice was quiet but firm. I'm not asking for your opinion on Dr. Thornton's value to the hospital. I'm not asking you to interpret or provide context. I'm asking to see documented complaints. As medical director, that's well within my authority. Patricia pressed her lips together, then opened the drawer she'd been reaching for earlier. She pulled out a file folder, but her hand hesitated before handing it over. There are complaints here, she said slowly, but you should know that none of them were formally pursued. In each case, after investigation, it was determined that Dr. Thornton's behavior, while perhaps not ideal, didn't rise to the level of actionable misconduct. I'll be the judge of that, Amara said, taking the folder. She spent the next hour reading through the file, and what she found made her sick. 12 formal complaints over the past 6 years. 12, all from nurses or other staff members, all describing variations of the same pattern: dismissive behavior, demeaning language, refusal to listen to medical concerns, and what several complainants described as racially biased treatment. One complaint from 2 years ago was from a nurse named Yolanda Martinez. She described being publicly berated for suggesting a patient might be having complications. Dr. Thornton had accused her of being dramatic and trying to create problems where none existed. The patient had coded 4 hours later. The investigation concluded that while Dr. Thornton's tone was unfortunate, his medical judgment had been sound, and the patient's decline was unforeseeable. Another complaint was from David Okonkwo, the nurse she'd seen that morning. It was dated 8 months ago. He described being told he should go back to whatever country he came from if he didn't like how American doctors practiced medicine. The investigation noted that Dr. Thornton denied using those exact words and claimed he'd simply suggested the nurse might be more comfortable in a different hospital environment. David's complaint was filed as unsubstantiated. A third complaint was from a nurse who'd since left the hospital. She wrote about Dr. Thornton creating such a hostile work environment that she'd developed anxiety about coming to work. The investigation recommended improved communication training for both parties. Every complaint followed the same pattern. Someone reported genuinely concerning behavior. The hospital investigated, and then the complaint was quietly dismissed as either unsubstantiated, taken out of context, or simply the result of personality conflicts. Amara closed the folder and looked up at Patricia, who'd been sitting quietly watching her read. Why? Amara asked simply, why what? Why were all of these dismissed? Some of this behavior is clearly inappropriate. Some of it potentially affects patient care. Why was nothing ever done? Patricia sighed. Dr. Williams, you have to understand the reality of running a hospital. Dr. Thornton is one of our top cardiac surgeons. He has excellent patient outcomes. His patients love him. He brings in millions in revenue. And yes, he can be difficult to work with, but a lot of brilliant doctors are difficult. We can't fire every physician who has a strong personality, or who sometimes rubs people the wrong way. This isn't about strong personalities, Amara said. This is about a pattern of disrespect and potential bias that's creating a hostile work environment and possibly affecting patient care. Possibly, Patricia repeated. But none of these complaints showed actual harm to patients, and we have to balance staff complaints against Dr. Thornton's value to this institution. Amara stood up, the file folder still in her hand. I'm taking this with me. And I'm opening a new investigation. Dr. Williams, I really think you should talk to the board before you. The board hired me to ensure this hospital operates at the highest standards of medical care and professional conduct. Amara interrupted. That's exactly what I'm doing. She left the HR office and went back to her own, finally opening the door to the space she'd been avoiding. The office was nice, bigger than any she'd had before, with windows overlooking the city and a desk that was probably worth more than her first car. But she didn't sit down to enjoy it. Instead, she opened her laptop and started making notes. Every incident she'd witnessed, every complaint in the file, Every nurse who'd looked uncomfortable or resigned or hurt. This wasn't just about one elevator ride anymore. This wasn't even just about her. This was about a system that had failed to protect its staff and potentially its patients. And Amara had spent her entire career fighting against exactly this kind of institutional failure. Her phone buzzed. A text from Kelly Chen, the nurse she'd seen that morning. "Dr. Williams, not sure if this matters, but Mr. Harris, the patient David was worried about, just went into VFib. We got him back, but thought you should know." Amara stared at the message, her heart sinking. David had been right to be concerned. His instincts had been correct, but he'd been dismissed, belittled, and made to feel like he was overreacting. How many other times had nurses been right and been ignored? How many near misses had there been? How many patients had suffered because someone was too afraid to push back against Dr. Thornton's arrogance? She typed back, "Thank you for letting me know. Is Mr. Harris stable now?" Yes, David stayed with him all morning. He probably saved his life. Amara set down her phone and looked out the window at the city below. Somewhere out there, people trusted this hospital to provide the best care possible. They trusted that the doctors and nurses would work together, would listen to each other, would put patient safety above ego and hierarchy. And this hospital was failing that trust. One doctor at a time, one dismissed complaint at a time, one nurse who learned to stop speaking up at a time, but not anymore. Not on her watch. The department meeting was scheduled for 2 o'clock on Friday afternoon in the largest conference room on the 3rd floor. Amara had seen it on the calendar during her first week, a monthly gathering where all the department heads discussed ongoing issues, shared updates, and addressed hospital-wide concerns. It was the kind of meeting that was mandatory for senior staff and optional for everyone else. Amara had decided to attend. But she wasn't going to sit at the table with the other administrators and department heads. Not yet. She wanted to see how people behaved when they thought the new medical director wasn't watching. She arrived 15 minutes early, wearing her scrubs and carrying a notebook. The conference room was already starting to fill up. Doctors in white coats clustered near the coffee station. Nurses grabbed seats along the walls. Administrative staff set up laptops and prepared to take notes. Amara found a chair in the back corner, away from the main table, and settled in to observe. Dr. Thornton arrived exactly at 2 o'clock, which seemed to be his style. Never early, never late, always making an entrance. He was talking loudly with another surgeon, laughing at his own joke. Several people looked up when he came in, and Amara noticed the subtle shift in energy. People sat up a little straighter. A few nurses exchanged glances. He grabbed a coffee and took a seat near the head of the table, directly across from where the chief of medicine usually sat. Amara recognized the power move. Dr. Thornton might not run these meetings, but he clearly saw himself as one of the most important people in the room. The meeting started with the usual administrative updates. Budget reports, new equipment purchases, upcoming inspections. Amara took notes not because she needed to remember the information, but because it gave her something to do while she watched the room's dynamics. Dr. Thornton looked bored, scrolling through his phone and barely paying attention. Several other doctors did the same. But the nurses, Amara noticed, were actually listening and taking notes. They were the ones who asked questions about the new equipment. They were the ones who wanted clarification on the new scheduling system. 20 minutes into the meeting, the chief of medicine, Dr. Alan Brewster, opened the floor for general concerns and comments. "Anyone have anything they'd like to discuss?" Dr. Brewster asked, looking around the room. There was silence for a moment. Then Dr. Thornton set down his phone. "I have something," he said, and Amara felt the energy in the room shift again, this time with a hint of anxiety. "Go ahead." "Richard," Dr. Brewster said. Dr. Thornton stood up, which seemed unnecessary for a departmental meeting, but apparently, he felt it added weight to whatever he was about to say. "I want to talk about standards, specifically about maintaining high standards in our hiring and in our daily operations." A few people nodded. It sounded reasonable enough. Who could argue against high standards? "I've been at this hospital for 15 years, Dr. Thornton continued, and I've seen a lot of changes in that time. Some good, some not so good. And lately I've been concerned about a trend I'm seeing." He paused for effect, looking around the room like a professor about to make an important point. "We're lowering our standards," he said flatly. In the name of other priorities, we're accepting mediocrity, and it's affecting patient care. Dr. Brewster frowned. That's a serious accusation, Richard. Can you be more specific? I can. Dr. Thornton started pacing slightly, warming to his topic. Just this week, I had a situation in the elevator. A nurse, someone I'd never seen before, tried to give me medical advice about a cardiac case, a complex cardiac case. She was looking at a chart and decided she knew better than the attending physician. Amara felt her pulse quicken, but she kept her face neutral, her eyes on her notebook. Now, I appreciate enthusiasm, Dr. Thornton continued. I really do, but there's a line between being engaged and overstepping. And when we hire people who don't understand that line, who don't respect the hierarchy that exists for very good reasons, we create problems. Did this nurse do something wrong? Someone asked from across the table. She questioned a treatment plan without having any of the necessary training or expertise to understand it, Dr. Thornton said. And the concerning part is she didn't seem to realize how inappropriate that was, which tells me she probably wasn't properly trained about professional boundaries. Kelly Chen, the nurse Amara had observed earlier in the week, shifted uncomfortably in her seat along the wall. David Okonkwo sat a few chairs down from her, his face carefully blank. I think you might be overreacting, Dr. Brewster said carefully. Nurses are trained to advocate for patients. If she had a concern, she should have gone through proper channels, Dr. Thornton interrupted. She should have spoken to the attending nurse, who could have spoken to me if it was truly necessary. But instead, she decided to approach me directly and challenge my medical judgment in front of other staff members. I'm not sure I see the problem with direct communication, another doctor said. If she had a patient safety concern, it wasn't a patient safety concern, Dr. Thornton said, his voice rising slightly. It was a nurse who didn't know her place, thinking she could play doctor. And this is exactly what I'm talking about. We've created an environment where everyone thinks their opinion is equally valid, where nurses think they can diagnose and treat, where medical hierarchy, which exists to protect patients, is seen as something old-fashioned or discriminatory. The word discriminatory hung in the air. Amara saw several people react to it, though most tried to hide it. I'm not saying this to be difficult, Dr. Thornton continued, his tone shifting to something that might have been intended as reasonable, but came across as condescending. I'm saying this because I care about this hospital and our patients. We need to make sure we're hiring people who understand medical hierarchy, who understand that doctors make medical decisions and everyone else supports those decisions. That's not controversial. That's just how medicine works. A young resident near the front raised his hand tentatively. With respect, Dr. Thornton, I think some of the best catches I've seen came from nurses questioning things. Just last month, a nurse noticed a medication error that could have... That's different, Dr. Thornton cut him off. That's a nurse doing her job, checking for errors in execution. That's appropriate. What I'm talking about is nurses trying to make diagnostic or treatment decisions that are way outside their scope of practice. He turned back to address the full room. And I know this is uncomfortable to talk about. I know some people are going to say I'm being too harsh or too traditional, but we have to be honest about what's happening. Standards are slipping. And if we're not careful, patient care is going to suffer. Dr. Brewster looked like he wanted to move on. Richard, I appreciate your concerns, but I'm not sure this is the right forum. This is exactly the right forum, Dr. Thornton insisted. This is where we talk about hospital-wide issues. And this is a hospital-wide issue. We need to be more selective in our hiring. We need to make sure people understand their roles. And we need to stop being afraid to maintain standards just because someone might call us discriminatory for expecting competence. There it was again. The word discriminatory used as a shield, as if anyone who disagreed with him was just being too politically correct to handle the truth. Just this week, Dr. Thornton went on, and Amara realized with a sinking feeling that he wasn't done. I had a nurse on my unit question my judgment about a post-op patient. The patient was showing completely normal post-surgical symptoms, but this nurse decided it was his place to try to change my treatment plan. David Okonkwo's jaw tightened. But he didn't say anything. When I explained that his concerns were unfounded, based on his lack of medical training, he became defensive. He said he was documenting his concerns, as if that was some kind of threat. This is what happens when we don't maintain clear professional boundaries. People start to think their feelings and hunches are as valid as medical expertise. The patient went into cardiac arrest 4 hours later, a voice said quietly from the back of the room. Everyone turned. David had spoken, his voice steady but his hands gripped tightly in his lap. Dr. Thornton's face reddened. That's irrelevant. The patient had a post-operative complication that was unforeseeable. It was foreseeable, David said, standing up now. His oxygen saturation was dropping. He had chest pain. His heart rhythm was irregular. Those aren't just feelings or hunches. Those are clinical signs that something was wrong. Clinical signs that can mean 100 different things, Dr. Thornton shot back, and which I, as the physician, assessed and determined didn't warrant changing the treatment plan. The fact that the patient later had a complication doesn't mean you were right. It means he had a complication. That's why it's called a complication. Because it's an unexpected development. It wasn't unexpected to me, David said quietly. I saw it coming. The room was completely silent now. Everyone watching the confrontation unfold. You saw it coming, Dr. Thornton repeated, his voice dripping with sarcasm. You, with your nursing degree, saw something that I, with my medical degree and 15 years of cardiac surgery experience, missed. Is that what you're saying? I'm saying I reported concerning symptoms and was told they were normal when they clearly weren't. They were normal, Dr. Thornton insisted. The patient's subsequent arrest was due to a blood clot that formed suddenly. There's no way anyone could have predicted it. Actually, another voice said from the side of the room, the signs David reported are consistent with early clot formation. Decreased O2 sat, chest pain, arrhythmia. If those symptoms had been taken seriously, imaging might have caught it earlier. Dr. Thornton whipped around to see who'd spoken. It was one of the other cardiologists, Dr. Helen Park, who'd been sitting quietly throughout the meeting. Are you seriously second-guessing my medical judgment right now? Dr. Thornton asked, his voice incredulous. I'm saying David was right to be concerned, Dr. Park said calmly. And maybe if we listened to nursing staff more often instead of dismissing them, we'd catch more of these things early. This is unbelievable, Dr. Thornton said, looking around the room as if seeking support. This is exactly what I'm talking about. Everyone's an expert. Everyone knows better. Nobody respects expertise anymore. Respect goes both ways, Richard, Dr. Park said. I respect people who've earned it, Dr. Thornton shot back. I respect people with actual training and credentials. What I don't respect is this new culture where we pretend everyone's opinion matters equally, in the name of being nice or inclusive or whatever the buzzword is this week. Inclusive, Amara said from the back of the room. Her voice wasn't loud, but something about her tone made everyone turn to look at her. She stood up slowly, closing her notebook. The buzzword you're looking for is inclusive. Dr. Thornton looked at her, and Amara saw the moment of recognition flash across his face. The elevator, the nurse who'd tried to talk to him about a patient. And you're right, Amara continued, walking forward from the back of the room. Not everyone's opinion matters equally in medical decisions. Medical expertise matters. Training matters. Experience matters. She moved through the room, and people shifted in their seats to watch her. Dr. Thornton's expression was morphing from recognition to confusion to the beginning of concern. You mentioned a nurse in the elevator who questioned your judgment about a cardiac case, Amara said, her voice calm and steady. Someone who didn't know her place. Someone who thought she could discuss cardiology without the proper credentials. Dr. Thornton's face was starting to pale. That was me, Amara said simply. I was that nurse, except I'm not a nurse. She reached the front of the room and turned to face everyone. I'm Dr. Amara Williams, the new medical director of this hospital, and before this position I spent 12 years as chief of cardiac surgery at Boston Memorial. Before that, I completed my residency at Johns Hopkins and my fellowship at Harvard Medical Center. I have over 60 published papers in peer-reviewed journals on cardiac pathology and surgical outcomes. The room was so quiet you could hear the air conditioning humming. So when I looked at that patient's chart in the elevator and expressed concerns about his troponin levels and EKG results, I wasn't a nurse overstepping. I was a cardiac surgeon with arguably more specialized training than you have. Dr. Thornton trying to discuss a case that concerned me. Dr. Thornton opened his mouth, but no sound came out. And you dismissed me? Amara continued. Not because my analysis was wrong. Not because my concerns were unfounded. But because you looked at me, saw my scrubs, saw my face, and decided you knew everything you needed to know about my qualifications. She pulled out the file folder she'd gotten from HR and set it on the table. This contains 12 formal complaints filed against you over the past 6 years. 12 incidents of you dismissing, belittling, and creating a hostile environment for staff members. And after reviewing these complaints and observing your behavior this week, I can see a very clear pattern. Dr. Thornton found his voice. Now wait just a minute. No, you wait, Amara said, and there was steel in her voice now. You've been talking for 20 minutes about standards and hierarchy and proper roles. So let me tell you about my role. My role is to ensure this hospital provides the highest quality of patient care in an environment of mutual respect and professional collaboration. And you, Dr. Thornton, are failing on both counts. She looked around the room, making eye contact with David, with Kelly, with the other nurses who'd been dismissed and belittled. Effective immediately, I'm launching a formal investigation into your conduct and its impact on patient care. And until that investigation is complete, you'll be working under direct supervision. The room erupted in whispers. Dr. Brewster looked stunned. Dr. Thornton looked like he'd been slapped. You can't do this, he said, his voice shaking with anger. I'm one of the best surgeons in this hospital. My patients, your patients deserve a surgeon who listens to his entire care team, Amara interrupted. And your colleagues deserve to work in an environment where their professional input is valued, regardless of their title or their background. She picked up the folder and walked toward the door. Before leaving, she turned back one more time. This meeting is adjourned. Dr. Thornton, please come to my office in 1 hour. We have a lot to discuss. And with that, she walked out, leaving a room full of stunned faces and finally, the beginning of change. Dr. Thornton didn't show up to Amara's office an hour later. He didn't show up 2 hours later either. Instead, at 4:30 in the afternoon, Amara received a call from the hospital's legal counsel, requesting an emergency meeting with her. Dr. Thornton and 2 members of the board of directors. She wasn't surprised. Men like Dr. Thornton didn't accept consequences quietly. They fought back. They called in favors. They made it about everything except their own behavior. The meeting was scheduled for 9 the next morning in the boardroom on the executive floor. Amara spent that evening preparing. She reviewed every complaint in Dr. Thornton's file. She organized her notes from the week of observations. She documented every incident she'd personally witnessed, and she made phone calls to each of the nurses who'd filed previous complaints, asking if they'd be willing to speak to the investigation. Some said yes immediately. Others hesitated. One, a nurse named Priya Kapoor who'd left the hospital 2 years ago, was blunt about her hesitation. Dr. Williams, I appreciate what you're trying to do, Priya said over the phone. I really do. But I've been down this road before. I filed a complaint. I told them everything. And you know what happened? Nothing. Dr. Thornton got a slap on the wrist and I got labeled as difficult. I eventually had to leave because the environment became impossible. I understand, Amara said quietly, and I can't promise you this will be different. But I can promise you that I'm not going to let this go quietly. I'm the medical director now and I have the authority to make real changes. With respect, the last medical director had authority too. So did the chief of medicine. So did HR. They all had the power to do something and they all chose not to. Then I'll be the first one who chooses differently, Amara said. But I can't do it without people being willing to tell the truth about what's been happening. There was a long pause. What do you need from me? Just tell your story honestly, that's all. Okay, Priya said finally. Okay, I'll do it. But if this turns into another cover-up, if they protect him again, I'm going public. I'll go to the news. I'm done protecting this hospital's reputation. Fair enough, Amara said. The next morning, Amara arrived at the boardroom 15 minutes early. She wore a professional suit instead of scrubs. Her credentials and documentation organized in a leather portfolio. She was ready for a fight. The board members arrived first. Robert Chen, who'd been on the board for 20 years and chaired the finance committee, and Linda Vasquez, the newest board member and a former hospital administrator herself. They both greeted Amara cordially but with obvious tension. Dr. Thornton arrived with 2 lawyers. Not the hospital's lawyers, his own. That told Amara everything she needed to know about how he planned to handle this. I want it on record that I'm here under protest, Dr. Thornton said before even sitting down, and that I consider this entire investigation to be a personal vendetta from Dr. Williams, stemming from a misunderstanding in an elevator. Noted, Linda Vasquez said calmly. Please sit down, Dr. Thornton. For the next 3 hours, they went through everything. Amara presented the complaints, the documented incidents, the pattern of behavior. She showed how Dr. Thornton's dismissal of nursing concerns had led to delayed interventions and near-miss events. She presented testimony from nurses who described a culture of fear and intimidation on the cardiac unit. Dr. Thornton's lawyers argued that he was being targeted for having high standards, that the complaints were from disgruntled employees who couldn't handle his expectations, that his surgical outcomes proved his methods worked. Your surgical outcomes are good, Amara acknowledged. No one is disputing your technical skill, but surgical skill doesn't give you the right to create a hostile work environment. It doesn't give you the right to dismiss valid medical concerns based on someone's job title or appearance. This is about the elevator, isn't it? Dr. Thornton said, leaning forward. You're embarrassed that I didn't recognize you, so now you're trying to destroy my career. This has nothing to do with my ego, Amara said evenly. This has to do with a pattern of behavior that's been documented for 6 years. A pattern that was allowed to continue because previous administrators prioritized your revenue generation over staff welfare and patient safety. Patient safety? Dr. Thornton's voice rose. I've never had a patient safety issue in 15 years at this hospital. Actually, you have. Amara pulled out another file. In the past 2 years alone, there have been 5 incident reports filed by nursing staff regarding patients under your care who experienced complications after you dismissed their concerns. In 4 of those cases, nurses documented that they'd reported warning signs that were ignored. Complications happen in cardiac surgery, one of Dr. Thornton's lawyers interjected. That's the nature of the specialty. You can't blame Dr. Thornton for every patient who has a setback. I'm not blaming him for complications, Amara said. I'm questioning why nursing concerns about those complications were systematically dismissed. I'm questioning why multiple experienced cardiac nurses felt their professional judgment wasn't valued or respected. Robert Chen, who'd been mostly quiet, spoke up. Dr. Williams, I understand your concerns, but we have to consider the broader picture. Dr. Thornton has brought significant prestige and revenue to this hospital. His patients are very satisfied. Many of them are major donors. We can't ignore the institutional impact of any action we take. I'm not asking you to ignore it, Amara said. I'm asking you to weigh it against the institutional impact of allowing discriminatory behavior to continue. How many talented nurses have we lost because of this environment? How many potential lawsuits have we narrowly avoided? How many patients received suboptimal care because their nurses were too intimidated to speak up? Those are hypotheticals, Dr. Thornton's lawyer said. No, they're not. Amara opened her portfolio and pulled out more documentation. 3 nurses have left the cardiac unit in the past 18 months, specifically citing Dr. Thornton's behavior. The unit has the highest turnover rate in the hospital. Exit interviews consistently mention the hostile work environment. And in terms of patient care, I have documented testimony from 4 nurses describing specific incidents where their concerns were dismissed and patients subsequently declined. She slid the papers across the table. These aren't hypotheticals. These are documented facts that previous administrators chose to ignore. Linda Vasquez picked up the papers and started reading. Her expression grew more troubled with each page. Furthermore, Amara continued, I've spoken with several of Dr. Thornton's colleagues in cardiac surgery. Off the record, 3 of them admitted they've witnessed concerning behavior but felt unable to report it because of Dr. Thornton's status in the hospital. One mentioned that they'd stopped consulting with him on complex cases because of his dismissive attitude toward input.